Okay, so welcome everyone to our Prescribing in Surgery series. This is our second session on fluids and electrolyte imbalance. My name's Aisha, Musa. I'm one of the F1 doctors and I'm co-lead for the Prescribing in Surgery series with Dr. Hermione Jemmett. So this is a Mind the Bleep medical research conference that we'll be doing. So if you guys could please, in your spare time, fill out the QR code on the slides. So this is the team. So Dr. Sona Petrosian is the lead for prescribing at Mind the Bleep, and Dr. Hermione Jemmett, as well as myself, are co-leads for the Prescribing in Surgery series. So just a disclaimer that prescribing in surgery, it's been created by junior doctors. It's entirely on a voluntary basis. We've, of course, tried our best to make sure that the slides are accurate to the best of our knowledge, but neither the tutors nor Mind the Bleep take responsibility for any unintentional inaccuracies. And this is the provisional dates for our Prescribing in Surgery series. So today's session will be on fluids and electrolyte imbalances, and next week's session with Dr. Hermione Jemmett will be on antibiotics and blood transfusions. So this is our first case, so case 1. A 70-year-old woman presents to A&E with a 4-day history of vomiting. Past medical history, she's got dementia, not currently on any medications. On examination, her respirate is 22, her oxygen saturation is 97% on room air, temperature 36.5, blood pressure 105/60, heart rate 120, heart sounds 1 and 2 present with no added heart sounds, chest is clear, cap refill is 3 seconds. She's got reduced skin turgor and a dry mucous membranes. In terms of investigations, her sodium is 139, potassium is 4.1, urea is 16, and creatinine is 130. So could you please, in the chat, write a prescription for one IV fluid that is most appropriate for the patient currently? And I'll give you 1 minute for this question. Okay, I'm just going to check the chat for responses. Okay, so for Harmons, okay, yep. Any other suggestions? Okay. Okay. So for this question, what we're assessing is fluid resuscitation in adults. So the correct answer is sodium chloride, 0.9% solution, IV 500 milliliters over 10 minutes. Alternative infusions that you could also give is Ringer solution, Plasmolite, and Hartmann solution. and we would give it over 500 milliliters under 15 minutes. So if we refer to the NICE guidelines of 2017, it says for IV fluid resuscitation, we need to give crystalloids that contain sodium in the range of 130 to 154 millimoles as a bolus of 500 milliliters over less than 15 minutes. So what tells us from the scenario that this patient requires fluid resuscitation is that the patient has signs of dehydration and hypovolemia. So the patient is tachycardic, hypertensive, tachypnic, and had dry mucous membranes as well as reduced skin turgor. And the patient's urea and creatine levels were also raised. So for the purpose of PSA in this kind of question, I would say to stick to 500 milliliters. But in clinical practice, if a patient is elderly, we tend to give 250 milliliters. And just to let you know that a volume less than 250 milliliters is not enough for a fluid challenge. And so correct answers would be anything under 15 minutes. So 15 minutes, 10 minutes, 5 minutes, even 2 minutes. Okay, I hope that helps. So the next case. So case 2, a 6-year-old boy presents to Pediatric A&E department with a 3-day history of diarrhea and vomiting. Doesn't have any medical conditions or doesn't take any medications. On examination, his respirate is 36, oxygen sats 98% on room air, temperature 36.5, and blood pressure 90/60, heart rate 140, heart sounds 1 and 2 present, no added heart sounds. His chest is clear, capillary refill is 3 seconds, has reduced skin turgor and dry mucous membranes. His weight is 15 kg. In terms of investigations, sodium's 139, potassium's 4.1, urea's 12, and creatinine is 85. So please, for this question, could you write a prescription of one IV fluid that is most appropriate for the patient currently? And can you please write it in the chat? And I'll give you 1 minute for this. Okay, please do write it in the chat. Okay. And we'll say now lactated drinkers IV 50 milliliters per kg bolus. Okay. Okay. So for this question, so the correct answer would be sodium chloride 0.9% solution IV. So it's 10 milliliters per kg, and this patient's weight is 15 kg. So you'd give 150 milliliters, and you'd give it 5 minutes. So alternative infusion fluids you could give is Ringer solution, Plasma-Lyte, Hartmann solution, and the NICE guidelines 2020 say to give 10 milliliters per kg under 10 minutes. So under 10 minutes would be 10 minutes, 5 minutes, and even 2 minutes. And so again, in the case, the patient, was hypertensive, had tachypnea, hypertension, tachycardia, reduced skin turgor. So we're looking at fluid resuscitation in children for this question. Okay. Okay, so now we move on to case 3. So case 3 is a 22-year-old man who's admitted on the medical ward for aspiration pneumonia. Past medical history, he's got cerebral palsy, he takes baclofen, and on examination, his respirate is 12, Oxygen sats 98% on room air, temperature 36.5, blood pressure 140/80, heart rate 70, heart sounds 1 and 2 present, no added heart sounds, crackles heard on auscultation, and he's judged to have an unsafe swallow. His weight is 80 kg. So investigation, sodium is 141, potassium is 4.3, urea is 6.8, and creatinine is 60. He's already had sodium chloride 0.9%, potassium chloride 0.3% bag, so 1,000 milliliters over 12 hours. So can you please write a prescription for 1 IV fluid most appropriate for the patient currently whilst he's nil by mouth? And again, if you could write in the chat. And I'll give you a minute for this question. Okay, no, we'll see that. Okay. Any other suggestions? Half 250 meters over. Okay. Anyone else? Okay. So for this question, what we're assessing is, we're assessing fluid maintenance in adults. So if you look at the NICE guidelines from 2017, it says in terms of daily requirements for patients that need IV fluids for routine maintenance alone, for example, if a patient's nil by mouth, they're awaiting operation, or if they have an unsafe swallow like our patient, they require 25 to 30 milliliters per kg per day of water, as well as 1 millimole per kg per day of potassium, sodium, and chloride, and 50 to 100 grams per day of glucose. Okay. So now if we look at the fluid infusion bags that are available, when we prescribe maintenance fluid, we give 8 to 12 hourly bags. So that means we give bags over 12 hours, 10 hours, or 8 hours. The fluid infusion bags available are, so you can give sodium chloride 0.9% with potassium chloride of 0.15%, or you can give sodium chloride 0.9% with potassium chloride 0.3%, or you can give glucose 5% with potassium chloride 0.15%, or glucose 5% with potassium chloride 0.3%. And in terms of the composition of the above bags, so sodium chloride 0.9%, 1 litre, contains 154 millimoles of sodium and chloride. Potassium chloride 0.50%, 1 litre, contains 20 millimoles of potassium. Potassium chloride 0.3%, 1 litre contains 40 millimoles of potassium, and glucose 5% over 1 litre contains 50 grams of glucose. I would say, in terms of maintenance fluid questions, stick to using the above bags, because if you use Hartmann's or Ringer's, 1 litre of both bags contain 5 millimoles of potassium, so that could kind of complicate things when you're trying to calculate daily requirements. And as you can see on the right, the combination of fluid bags available can be found on the BNF. And this table just gives you a composition of the commonly used crystalloids in more depth. So for this question, the way that I would calculate it is, as this patient's weight is 80 kg, we know that his water requirements would be 25 milliliters per kg times 80, which is 2,000 milliliters, and then 30 milliliters per kg times 80 kg, which is 2,400 milliliters. So his daily requirement for water is 2,000 to 2,400 milliliters. And in terms of his sodium or chloride requirement, it would be 1 millimole per kg times 80 kg, which is 80 millimoles of sodium / chloride. And his daily requirement of potassium is 1 millimole per kg times 80 kg, which is 80 millimoles of potassium. And adults' daily requirement of glucose is 50 to 100 grams. So the question stated that the first bag given was sodium chloride 0.9%, potassium chloride 0.3%, 1,000 milliliters over 12 hours. So that means this patient's already been given 1,000 milliliters of water, 154 millimoles of sodium and chloride, as well as 40 millimoles of potassium. So that means in our second bag, we need to give 1,000 to 1,400 milliliters of water. We don't need to give this patient any more sodium or chloride. We need to give them 40 millimoles of potassium and 50 to 100 grams of glucose. So that means the second bag we give for this patient is glucose 5% / potassium chloride 0.3% solution, 1,000 milliliters over 8 to 12 hours. That's because this bag will contain 1,000 milliliters of water, 40 millimoles of potassium, and 50 grams of glucose. I hope that makes sense. Okay, so now if we move on to our next case. So in case 4, we have a 56-year-old woman who presents to A&E with a 2-day history of diarrhea, which she said started after eating takeaway. In terms of her past medical history, she's diagnosed with hypertension, for which she takes amlodipine 5 milligrams daily. On examination, her respiratory rate is 12, her oxygen sats are 99% on room air, and her temperature is 36.2. Her blood pressure is 140/80, and her heart rate is 80. Heart sounds 1 and 2 are present with no added heart sounds, and her chest is clear. Her weight is 80 kg. In terms of investigations, her sodium is 131, potassium 3.2, urea 5.4, and creatinine 60. So the question is, could you please write a prescription for one IV fluid that is most appropriate for the patient currently? So, I'm going to give you guys a minute for this question. Any suggestions for this question? Okay. Hartmann's 500 milliliters over an hour. Okay. Any other suggestions? Okay, that's fine. Okay, fine. So for this question, what we're assessing is fluid maintenance and replacement in adults. Okay, so NICE guidelines 2017 says that we should adjust the IV prescription to account for any existing fluid and or electrolyte deficits or loss. Okay, so this patient has diarrhea. So if we look at the diagram on the right, it says that when you have diarrhea, you're losing your sodium, your potassium, and your bicarb. In the question, the sodium and the potassium were just below the normal range, but if the patient continues to have diarrhea, it will worsen, and therefore we need to prescribe fluids that will replace the sodium and the potassium that's being lost. Therefore, the correct answer would be to give sodium chloride 0.9%, potassium chloride 0.3% infusion fluid. We would give this IV, and we would give 1,000 milliliters over 46 hours. So it's better to prescribe infusion fluid containing potassium chloride 0.3% solution instead of potassium chloride 0.15 solution. The reason being is that the patient's weight in this question is 80 kg, so their daily requirement of potassium is 80 millimoles. And the patient's also losing around 30 to 70 millimoles of potassium because of the diarrhea. So it's better to prescribe potassium chloride 0.3% solution, which contains 40 millimoles of potassium, rather than 0.15%, which contains 20 millimoles of potassium. And when prescribing fluids for maintenance and replacement, instead of giving an 8 to 12 hourly bag, we prescribe 4 to 6 hourly. So we prescribe it a lot quicker, and that's to replace the loss or deficits. So 4 to 6 hourly bag means you can prescribe over 6 hours, 5 hours, or 4 hours. Okay, yeah, I'm starting to see suggestions that say over 6 hours, 4 hours. Okay. So the suggestions are in the chat. People are saying Hartmann's sodium chloride, normal saline. Yeah, so you'd give sodium chloride with potassium replacement. Okay, because they're losing the potassium because of the diarrhea. I hope that makes sense. Okay, so our next case 5. So there's an 11-year-old girl who's admitted to the pediatric ward and treated for tonsillitis with clarithromycin. Past medical history, she's got rheumatic fever, and she doesn't currently take any medications. She's allergic to penicillin. On examination, her respirate is 12, her oxygen sats are 99% on room air, her temperature is 36.5, blood pressure is 130 over 80, heart rate is 80, heart sounds 1 and 2 present, no added heart sounds, her chest is clear, and her weight is 35 kg. In terms of investigations, her sodium is 139, her potassium is 4.2, urea is 5.4, creatinine is 40. So for this patient, can you please calculate the 24-hour maintenance fluid requirement, and can you put it in the chat? And I'll give you guys a minute for this question. Any suggestions for this question? Okay. Anyone managed to calculate the 24-hour maintenance fluid requirement? Okay. If not, that's fine. We can calculate it together. Okay, so I'll go through the explanation. So if we look at the NICE guidance from 2020, it says to calculate the routine maintenance IV fluid rates for children and young people, we need to use the Holiday-Segar formula. And what that says is that you would give 100 milliliters per kg per day for the first 10 kg of weight. You would then give 50 milliliters per kg per day for the next 10 kg. And then 20 milliliters per kg per day for weight over 20 kg. On the right, you can also see a table that is found on BNFC if you go on the fluids and electrolytes page. So you don't need to memorize the Holiday-Segar formula for your PSA exams. So if we use the Holiday-Segar formula for this patient, so the patient weighs 35 kg, so her weight's over 20 kg. This means for the first 10 kg, we would give 10 kg times 100 milliliters, so that's 1,000 milliliters. For the next 10 kg, we would give 10 kg times 50 milliliters, which is 500 milliliters. And for her remaining weight, which is 15 kg, we would give 15 kg times 20 milliliters, which is 300 milliliters. So her total fluid maintenance is 1,800 milliliters over 24 hours. Does anyone have any questions? Okay. If not, I'll move on to the next question. Okay. So now we move on to case 6. So case 6, an 80-year-old woman is admitted to the trauma and orthopedics ward after surgery for her neck of femur fracture. Ward doctors have been asked to see the patient as she becomes unconscious after the ward round. Past medical history, she's got type 2 diabetes, for which she takes metformin 500 milligrams 3 times a day with meals. On examination, her respirate is 12, her sats are 95% on room air, her temperature is 36.5, blood pressure is 140/70, heart rate is 90, heart sounds 1 and 2 present, no added heart sounds, her chest is clear, and her blood glucose test is 1.3. She's unresponsive to glucagon after 10 minutes. Could you please, in the chat, write a prescription for one IV fluid that is most appropriate for the patient currently? Okay, so we've got someone said 10% glucose status. Okay. Any other suggestions? Okay. 50 milliliters IV. Okay. Okay. So the key thing for this question is to note that this patient has severe hypoglycemia. The finger prick glucose test is 1.3. The patient's unconscious and is unresponsive to glucagon after 10 minutes. Okay. So if you look at the BNF NICE guidelines, it says if the hypoglycemia is prolonged or if the patient is unresponsive to glucagon after 10 minutes, we would give a glucose 10%, and we would give 150 to 200 milliliters over 15 minutes. Or we would give glucose 20% IV, 75 to 100 milliliters over 15 minutes. So an advice I'd give you guys is to kind of try and stick to learning one volume. So for example, for me, I learned glucose 10%, 200 milliliters, or glucose 20%, 100 milliliters, rather than learning the range and maybe getting it confused. So I hope that helps. So if we then check the BNF guidelines, it includes kind of more in depth on how to treat hypoglycemia. So if you go on the BNF medical emergencies in the community section, it's got detailed guidelines on how to treat hypoglycemia. So of course, first line is by mouth. We would give a glucose liquid, or if the patient is conscious but uncooperative, we would give buccal administration. If the oral route cannot be given is when we give the glucagon injection, and if the hypoglycemia is prolonged or if the glucagon is not working after 10 minutes is when we give the glucose 10% or glucose 20%. I hope that makes sense. Okay. So our next case is case 7. A 45-year-old man is being treated in A&E for burns secondary to a house fire. During admission, he suddenly develops palpitations and chest pain. So his past medical history's got eczema. On examination, respirate 12, oxygen sats 97% on room air, temperature 36.5, blood pressure 140/70, heart rate 100, heart sounds 1 and 2 present, chest clear. So in terms of investigations, sodium's 140, potassium 6.6, urea 7.6, creatinine 85, ECG shows tall-tented T waves and flattened P waves. So please in the chat if we could write a prescription for one IV fluid that is most appropriate for the patient currently. And I'll give you guys a minute for this question. Any suggestions for this question? Okay, so ringers, Okay. So in this case, what we were assessing is that the patient has severe hyperkalemia. So the patient's potassium was above 6.5. So if we check the NICE guidelines, what it says is that you would give calcium chloride 10% or calcium gluconate 10%, and that would be to temporarily protect against myocardial excitability. And then we would prescribe insulin glucose and salbutamol to reduce the plasma potassium concentration. We would only give salbutamol if there was no tachyarrhythmia present. So if we look at guidelines from the Renal Association 2020, so in this case, it's severe hyperkalemia because the potassium was 6.5. There were ECG changes present. There was peaked T waves as well as flattened P waves. Therefore, what we need to prescribe initially is calcium chloride or calcium gluconate IV. So the correct answers would be calcium chloride 10% IV, 10 milliliters over 5 minutes, or calcium gluconate 10% IV, 30 milliliters over 10 minutes. So if we look at the Renal Association guidelines, it does say that we can give calcium gluconate 10% over 5 minutes. But if we refer to the NICE guidelines, 2024, it says that 30 milliliters of calcium gluconate needs to be given over 10 minutes. So for kind of exam purposes, I would say to follow the BNF guidelines and give it over 10 minutes. So yeah, I've seen someone say normal saline and Ringer's lactate. So to treat hypokalemia as an initial infusion fluid, we would give calcium chloride 10% or calcium gluconate 10%. And that's to protect the heart against the effects of the hypokalemia. I hope that makes sense. So now we go through case 8. So case 8, a 30-year-old woman presents to A&E with myalgia and generalized weakness. Past medical history shows that she has acne vulgaris, for which she takes benzoyl peroxide. On examination, her respirate is 12, her oxygen stats is 96% on room air, temperature 36.5, blood pressure 140/70, heart rate 90, heart sounds 1 and 2 present, no added heart sounds, chest is clear. In terms of investigations, her sodium is 140, potassium is 2.2, urea is 5.4, creatinine is 60, and her ECG shows ST depression and a prominent U wave. So please kindly in the chat, could you write a prescription for one IV fluid that is most appropriate for the patient currently? Any suggestions for this question? Okay, we can go through it together. So in this scenario, the patient has severe hypokalemia, and her potassium is 2.2. She has myalgia and generalized weakness, which are signs of hypokalemia, and she's also got ECG changes with SD depression and a prominent U wave. So if we check the BNF guidelines from 2024, it says that the initial treatment for correction of severe hypokalemia is potassium chloride with sodium chloride. They said that initial potassium replacement therapy should not involve glucose infusions because glucose can further decrease the potassium concentration. And the max rate that we can give potassium without ECG monitoring is to give 10 millimoles per hour. We already know that potassium 0.3% contains 40 millimoles of potassium. So the shortest duration without ECG monitoring is 4 hours. Therefore, the correct answer is sodium chloride 0.9%, potassium chloride 0.3% solution, IV, and to give 1,000 milliliters over 4 hours. For the purpose of the PSA, I would stick with a max rate of 10 millimoles per hour. In practice, with ECG monitoring, we can give a max rate of 20 millimoles per hour. Also in practice, we need to check the magnesium level and correct it, as low potassium can be caused by low magnesium, and if you don't treat low magnesium, it can make it difficult to treat low potassium. I hope that makes sense. So, case 9. A 60-year-old man presents to A&E with nausea, constipation, and painful bones. He's not diagnosed with any medical conditions, and he takes calcium supplements. On examination, his rest rate is 12, oxygen sats 98% on room air, temperature 37, blood pressure 140/80, heart rate 80, heart sounds 1 and 2 present with no added heart sounds, chest clear. Investigations. So his calcium's 3.5, his sodium's 142, his potassium's 4.4, urea's 5.7, creatinine is 60. So please in the chat, could you write a prescription for one IV fluid that is most appropriate for the patient currently? And I'll give you a minute for this question. Okay, someone said 10 millimole potassium over 12 hours and normal saline over 8 hours. Okay. Any other suggestions? So this case shows severe hypercalcemia. So if you think about the causes of hypercalcemia, it could be caused by dehydration or excessive calcium supplements. And the symptoms are kind of painful bones, nausea and vomiting, constipation, and can also present with psychiatric symptoms like anxiety or depression. And we can see from the investigations that this patient's calcium is 3.5. The normal range is between 2.14 and 2.51. So in terms of the NICE guidelines for severe hypercalcemia, they said that the first thing we should correct is dehydration, and we should correct this with the IV infusion of sodium chloride. We should also stop drugs like thiazides and vitamin D compounds. And bisphosphonates are useful, and permethrinate is most effective. So when we already know when prescribing fluids for maintenance and replacement, instead of giving the 8 to 12 hourly bag, we need to give 4 to 6 hourly bag because we're replacing a deficit. So the correct answer would be sodium chloride 0.9% IV, 1,000 milliliters over 4 to 6 hours. In severe hypercalcemia, because we're correcting dehydration, we tend to give around 2 to 3 liters over a 24-hour period. But of course, we need to be more careful and consider reducing the total daily volume if the patient is elderly or has heart failure. If you do give IV permethrinate, you need to make sure to monitor calcium and phosphate because it lowers the levels and can cause seizures if the levels become very low. I hope that makes sense. So this is our last case for today. So this is case 10. A 30-year-old woman presents to A&E with perioral paresthesia and muscle cramps. Past medical histories, and she's diagnosed with anxiety for which she takes sertraline. On examination, her respirate is 12, her oxygen sats are 98% on room air, her temperature is 36.5, blood pressure 140/70, heart rate 90, heart sounds 1 and 2 present with no added heart sounds, chest is clear, her Trousseau's sign is positive and Schwarz's sign is positive. Her calcium is 1.5, sodium 141, potassium 4.3, urea 6.3, creatinine 60, and her ECG shows a prolonged QT. In the chat, could you please write a prescription for one IV fluid that is most appropriate for this patient initially? Any suggestions for this question? Okay, we can go through this together. Okay, someone said calcium gluconate and normal saline. Okay. Thank you. So this case shows severe hypocalcemia. So symptoms that, I just go back to the case quickly. So the patient has perioral paresthesia, has Trousseau's signs positive, which is the carbopedal spasm. When the brachial artery is occluded when you use a pressure cuff, and the Schwarzschild sign is facial muscle twitching when you tap the parotid. There's also prolonged QT shown in the ECG. So nice guide. So the BNF 2024 says that you would give initial slow IV injection of calcium gluconate 10%, followed by continuous IV infusion to prevent reoccurrence. So initially you'd give 10 to 20 milliliters calcium gluconate injection 10%, followed by continuous IV infusion, initially 50 milliliters per hour, and you adjust according to the response. And you'd administer it using 100 milliliters of calcium gluconate 10% diluted in 1 litre of glucose 5% or sodium chloride 0.9%. In clinical practice, make sure to give the infusion after to ensure the patient doesn't become hypocalcemic after the initial IV injection. This question was asking for the initial IV fluid. So the initial IV fluid is calcium gluconate 10%. So you can give 10 to 20 millilitres over 5 to 10 minutes. So if you decide to give 10 millilitres, you give that over 5 minutes. But if you decide to give 20 millilitres, you give that over 10 minutes. And then in clinical practice, you'd have ECG monitoring and you would give repeats as required. So this is just illustrating what we mentioned earlier, which is that if you give 10 millilitres of calcium gluconate 10%, you'd give it over 5 minutes, and you'd also do ECG monitoring and calcium monitoring. And also to prevent recurrence, you'd give a continuous infusion after. So these are the references. And this is a feedback form. If you could kindly please fill out the feedback form. It helps guide us for our future sessions. It lets us know what went well and how we can improve. And it also allows you to get a certificate of attendance. And the next session is on the 6th of March on antibiotics and blood transfusions, which will be delivered by Dr. Hermione Jemmett. Thank you for attending today's session. Any questions? I see some questions have already been answered. Any slides anyone wants me to go over? Okay. Okay, if there's no questions, then thank you for attending today's session, and please do fill out the feedback form. I'll just send it here as well. Okay, thank you. Thank you, guys. Thank you so much.